Dr. Noha, are you with us?
Okay, I am definitely.
Yeah,
better,
welcome.
Much more better.
Welcome, Prof Noha. Really, it's amazing really to have you again. So it deserves actually
Thank
to
you.
start again by introducing you again. Professor Noha is our expert in the field of the critical care management and the intensive care in Ain Shams University. She's the head of the critical care management, and she had a very wide experience in the field of nutrition based on her qualification in the parenteral and enteral feeding as well from the European Society of Enteral and Parenteral Nutrition. And she had definitely a huge record of publications in the national and international journals. She's a member and she's been reviewing too much endeavors in the field of education, the higher education society in Egypt, as well as her input as an instructor in many of the critical care courses within Ain Shams University. I would like really to give a very warm welcome to Professor Noha, and I'm sure that we're gonna enjoy this critical aspect of the management of the critically ill patient. It's over to you.
Thank you for having me. I assure you can hear me and see the slides right now.
Yes, I can see the slide. I can hear you very.
Okay, thank you. Thank you, my dear colleagues and professors, for having me and granting me this opportunity to present nutrition in critically ill patients. By the end of our presentation, we will be able to know what's malnutrition and critical illness relation. Assessment of ICU.
Go ahead. Yeah.
It's fine. Okay.
That's fine.
Assessment of ICU patient, enteral nutrition, parenteral nutrition, finally, never the least, immunonutrition. And I've added a few recommendations with respect to the current pandemic COVID-19. Malnutrition is simply a state of imbalance. It's either deficiency or excess that can affect the body organ in its function and composition. Simply, you can define it by a body mass index less than 18.5 kilogram per meter square, or an unintended weight loss of more than 10% in 3 to 6 months in previous 3 to 6 months, or a body mass index of less than 20, a body mass index of less than 20 kilogram per meter square with an unintentional weight loss of more than 5% in the previous 3 to 6 months. Why does it develop in critically ill? Because critically ill are heterogeneous group. They vary with different pathophysiologies and stresses to the whole body, and especially immunosuppression. This cause impaired intake, impairment in gut function, altered nutrition requirement, excess nutrition loss, and nevertheless, the critically ill is known for their hypercatabolism with loss of lean body mass. So the patient gets malnourished and loses his lean body mass. Most probably, this will affect by literature and evidence. It increases morbidity and mortality, increasing length of hospital stay, impairing tissue function, wound healing, defective muscles, and causing immunosuppression. It was documented and stated that the patient critically ill in staying in bed loses around 2% per day of his whole muscle proteins. So how to assess? There are two methods of assessment. First, you assess for the probability of this patient suffering malnutrition, and this is done by using the Nutric or the mini Nutric score. The difference is actually just in a single parameter, which is the interleukin-6. The Nutric score was designed by using the age, the Apache, the SOFA score, number of comorbidities, and the days from the hospital to ICU admission, and the interleukin-6. Then they found that interleukin-6 is not used routinely worldwide, and it's cumbersome to wait for it. And thus, they removed the interleukin-6 and done a mini Nutric score. The mini Nutric score and the Nutric score predict the probability of suffering malnutrition. So if it's from 5 to 9, then this patient would probably need an intervention because he will suffer malnutrition. If it's a low score, then this patient would not need a clinical nutrition intervention. This is the Apache score we're all familiar with. This is our SOFA score. So if we assess for malnutrition, we should put in mind what nutritional requirements do we need for this patient. We have to count for the basal metabolic rate with some additional factors as stress, the activity, the thermogenesis, which is the energy required for the metabolism of food. Protein requirement most probably would be from 1 to 1.5 gram protein per kg, and it would increase during stress and even in burn up to 5 grams per kg proteins. Fluid requirements are important as a part of the nutritional management of these patients. It's 30 ml per kg for those who are above 60 years and 35 ml per kg for those who are below 60 years. Estimated calories are basically done either by adjusted body weight and using equation or with the golden standard for critically ill patient, which is the indirect calorimeter. We would calculate our calories and add the activity factor, the stress factors, knowing that our protein varies from 1 to 1.5 as basal requirement and increases with stress. This is a slide stating the adjusted body weight, how to be able to calculate it, and just a rough figures that we all use using our BMI to calculate the requirements. To simplify it, which is the energy requirement kilocal per kg per day. So within the normal range is 20 to 29, so it's 20 to 25 kilocal, the one we're all familiar with. When the body mass index decreases, the caloric needs increase. And those who are morbid obese or even super obese, this is no time to lose weight. You'd give them the regular 15 to 20 kilocal per kg. So we have calculated our calories, and now we must identify the route, what to give, how to give it, and when to give it. So the route, we have two routes, either the enteral route or the parenteral route. The enteral route, it starts from the mouth by starting with just meshing food. And then you go for the next step, which is fortifying food. You add things to increase the caloric requirements, which is fat, carbs, and protein to the food in the form of either powders or increase your butter in the food to increase the calories. And then you go for, after this, for the oral nutritional supplements and oral nutrition supplements with its all type, which is going to be discussed later on. The enteral route has an advantage. It's physiological. It maintains the integrity of the GIT and prevent colonization. Of course, less costly, less complication, especially septic ones, but it has a major disadvantage, the risk of aspiration, and requires a gastric function with good gastric emptying. However, we must know that it's enteral, and then you resort to your parenteral, if not possible, the enteral feeding. Total parenteral nutrition, you use it in bowel surgery, obstruction, ileosis, chronic and severe malabsorption, when you do not have a gut that you can access. The disadvantage, of course, are the loss of your intestinal mucosa in the form of mucosal atrophy, other catheter-related sepsis, because most of them are hyperosmolar, so they need a wide access as a central venous access. And of course, they are expensive in relation to the enteral nutrition. So we knew the route. Now we go for our types. We have a standard type and we have specific, and both of them for the enteral and parenteral, we do have the same. So the standard are the standard bands, carb, proteins, and lipid, and the specific, the one they go for the diabetic, renal, hepatic, and even the pulmonary. And nowadays, the immunonutrition is gaining publicity, especially in the era of the current pandemic, COVID-19. Omega-3 fatty acid is considered an immunonutrition, as well as branched chain fatty acid, glutamine, vitamin, and trace elements. What's the indication? All patients not expected to be on a full oral diet within 3 days should receive an enteral nutrition. And this is a grade C recommendation. And definitely enteral nutrition is preferred over parenteral. And to do so, you must have a functioning gut with sufficient length and absorptive capacity. It's as soon as possible, as long as the patient is not malnourished. But if the patient is malnourished and expected not to be able to eat or drink for 5 to 7 days, he should receive an enteral nutrition support. If he's normally nourished, you can wait to 7 to 9 days. In those patients who are not expected to meet their oral intake, as those who are severely hypercatabolic as the burn patient, it's an indication to use this tube feeding, as well as those who are unable to use their oral intake, resulting in deterioration of their general condition and delayed recovery. Timing as soon as possible within the first 24 hours. But you do have some important things to consider. First, that enteral nutrition and parenteral nutrition are both contraindicated in shocked patients. So to use the enteral nutrition, you should have a patient who is hemodynamically stable. And if you're using vasoactive drug, as some of our patients in ICU, just after hemodynamic stabilization, you should use a trophic feeding, which is 10 to 20 ml per hour, starting dose. In the critically ill patient, it's important to know that you go slow and you escalate from point to another. Also, enteral nutrition should be withheld in those with severe shock as lactic acidosis, mesenteric ischemia, intestinal obstruction, or bleeding. Fruit is either oral, as we said, a mashed food, you mash it with the fork, or you simply increase its fortification by adding powdered proteins, or you can make it much more palatable. You can slice it into small slices, make sure that the patient has his dentiture on and there is no problem with respect to swallowing and cutting the food. If not, you go for the tube feeding. And the tube feeding is either nasogastric nasojejunal or percutaneous endoscopic gastrostomy jejunal-stomies, or even surgical. Common fed used in ICU would be our standard formula, which is 1 kilocal in a 1 ml for most of the patients. You may have patients who need much more energy, which is 1.5 kilocal. This formulas, however, has a problem of fluid restriction, and these formulas would benefit patients in the form of those who need fluid restriction, but they are mostly hyperosmolar forms. Also, there are some concentrated 2 kilocal per ml, which are also hyperosmolar, but they are used in those patients with renal patients with high blood electrolyte and fluid restriction. The low sodium formulas, and this is used for intracranial hypertension, and peptide formulas, which are used for malabsorption and indigestion. The tube feeding indications. The tube feeding, they are used for short-term feeding. They need an intact gag reflex, a proper gastric function, and they give you the advantage of low risk of aspiration. However, there are some disadvantages. They are not suitable for patients with compromised gut. They may promote nasal necrosis and esophageal necrosis or esophagitis, predisposed to sinusitis, and impair the quality of life as the patient is not comfortable with, and probably they may increase the risk of aspiration in some patients. As for nasojejunal and jejunal tubes, the indications would be that they are high risk of aspiration, and the gut function needs gut function compromise. Advantages: allow for initiation of early enteral feeding and may decrease the risk of aspiration. However, they carry some disadvantages of that of the nasogastric, which are probably increasing nasal necrosis, promoting nasal necrosis and esophagitis, predisposing to sinusitis and impair the quality of life. Moreover, they are difficult in placement and are limited by the amount that you can put in, which is the continuous inflow. You cannot put more than 150 to 200 ml in per feeding for this patient. and they must be continuously. On the other hand, the nasogastric tube, you can put the volume which is much more higher than this. The gastrostomy, this is for long-term placement, most probably more than 4 weeks. It needs an intact gastric function, and it has a disadvantage that it requires surgery. The stomach care may be somehow difficult for some patients. There are potential problems of leakage, tube dislodgement, and site infection and clogging. When you're using your enteral route, you have to put in mind that you have to optimize this by simply starting early, elevating the head of bed. These protocols must be nurse-driven. The nurse must know what she's doing, what's the complication anticipated, how she's putting the formulas, when to discard it. It's better to use a closed system with a commercially prepared formulas rather than homebrew. And if the patients suffer any illness or disturbance in the gastric motility, you should consider optimizing prokinetics, and post-pyloric tube feeding is recommended in those with high risk of aspirations. Everything in life has a contraindication, even enteral feeding. So when it's contraindicated, when you cannot gain an access, when there is intestinal obstruction, when there is a high output fistula, or the patient simply is hemodynamically unstable, or even during resuscitation, ileus, severe acute pancreatitis, not tolerating oral intake or enteral or tube feeding, intractable vomiting or diarrhea with its various causing, including anorexia nervosa and severe gastric bleeding, of course, GIT bleeding. Complication of tube feeding would be the device, its displacement or misdisplacement, the risk of aspiration, bronchopulmonary aspiration, and gastric intolerance in the form of vomiting, and this can be identified by a high gastric residual volume. Diarrhea due to either infection, nosocomial infection, or non-infectious diarrhea from medication. There are mechanical tube complications as blocking, clogging, and it has a certain management. First, you try with using warm water, and you try to flush the tube. Most probably, this is prevented by just asking those who implement the tube feeding to continuously flush the tube after the fed, and make sure the tube is quite okay, and use the proper formulas. Avoid homebrew that can clog. When you're using medication, change your medication to syrup form instead of having tablets crushed. Beware of nutrient and drug interactions, and other metabolic abnormalities can happen as acidosis and alkalosis. So if we have a patient, you should consider the medical history, pancreatic function, biliary insufficiency, and malabsorption. If these are present, you go for the semi-elemental peptide diet. If not present, then see what condition do you have. If you need a fluid restriction, then you try the hyperenergetic formulas. If you do have a gastric residual volume and you're using a hyperosmolar, so if you have a high gastric residual volume, you should avoid hyperosmolar formulas. Diarrhea, you go for fiber enriched. And if none of these is present, then it's okay to use the standard formula. So if enteral nutrition is contraindicated, the proposed frame to start parenteral nutrition in critically ill patient would be first to assess if the patient can match his resting energy expenditure 50% of it in the coming 3 days. If this is possible, then it's okay. If it's not possible to achieve the 50% of resting energy expenditure, then you should screen for the contraindication to enteral nutrition. If there is contraindication to enteral nutrition, then you assess the risk of malnutrition. If it's high, then you go for parenteral nutrition. If it's not high, you can wait for the coming 3 to 4 days as stated before, and then assess your patient again. If still enteral nutrition is contraindicated, you go for the total parenteral nutrition. On the other hand, if enteral nutrition is not contraindicated, so you start see if you can use it, use the enteral route, using the oral route first by meshing and fortifying as stated before, or then if not applicable, then the tube feeding, and you start gradually with 25 kilocal per kg per day and escalate. Beware of refeeding syndrome when you're considering parenteral nutrition. If the patient is on enteral nutrition, you have to assess your patient regularly for the risk of malnutrition. If there is a risk of malnutrition, you should consider putting supplemental parenteral nutrition. What are the indications of parenteral? Are short-term and long-term indications. Short-term indications are severe pancreatitis, mucositis, gut failure, if the patient has nothing by mouth, and these are very few nowadays, if the patient has a high output fistula, intractable vomiting, or severely malnourished and unable to establish enteral nutrition. Long terms are inflammatory bowel syndrome, radiation enteritis, other motility disorders, short-term bowel, and chronic malabsorption. The basic forms of parenteral nutrition for the total parenteral nutrition would be to calculate your fluid intake or water intake, and then you can calculate your energy requirement in the form of, as we stated before, according to our equations, or using your indirect calorimeter. And then it's composed of an amino acid, a carb, and lipids. Do not discard your mineral vitamin intakes in the form of your RDAs. So if we're using the parenteral nutrition, we have some types, and we can use different sites. The sites of the central venous axis or a peripheral, and this would be indicated by the patient condition, and if we're using total or partial parenteral. A partial parenteral nutrition would be a supplemental one to the enteral route used. We can use different single bottles or all-in-one forms. The timing would be early without delay, especially in those malnourished patients. Is there a problem? Okay, early without delay in those patients as soon as possible. In stable patients within 48 hours of ICU admission, especially those not expected to receive enteral nutrition for more than within the coming 5 to 7 days, and they should be hemodynamically stable. However, TPN has complications as overfeeding, refeeding syndrome, hyperglycemia, lipidemia, azotemia, fluid overload, hepatic dysfunction, respiratory compromise, and sometimes excess CO2 that cause difficulty in weaning. There are also catheter-related septic complications, the possibility of the occurrence of hypercholoremic metabolic acidosis and other electrolyte disturbance, abnormal liver functions, and deficiencies of thiamine, vitamin K, and folate. Immunonutrition is an important aspect nowadays of the nutritional requirements for patients. Glutamine was regarded before as the magic bullet, but nowadays it has its certain indications, which is aiding in the immune function in some subset of critically ill patients, and it's absolutely contraindicated in septic patients. Branched chain amino acid, and they are used to support the immune cell functions. Omega-3 fatty acids, which already proved to decrease inflammatory response and modulate immune system, and nevertheless, vitamins and trace. In any patient requiring clinical nutrition, you would have to finally monitor for the patient improvement. And this would be done by using a lab, some certain labs as pre-albumin, the transferrin, electrolytes, serum phosphate, calcium, magnesium. You monitor the patient random blood sugar, you monitor triglyceride level, and you monitor the hemoglobin and CBC. The transferrin half-life is 9 days, and the pre-albumin is 24 to 48. Nitrogen balance was used and still used by some facilities. It's cumbersome, but it can be done over 12 to 24 hours. functional performance of the patient is important in the form of the hand grip. With the last section of my presentation would be guiding principles and concern relevant to COVID-19 patient in nutrition critical ill. First of all, you have to decrease the number of staff. So you use ICU care, practicing cluster care to limit exposure, use your PPE. You should know that your older patient has pre-existing malnutrition and may suffer sarcopenia. Put in your mind that this patient would be very high risk for the problems of refeeding syndrome. Mostly COVID-19 patients suffer acute respiratory distress for a while, and they may be put on an ECMO. They may suffer circulatory failure and multi-organ dysfunction syndrome and hemodynamic instability, which would put this patient into problems when considering their enteral nutrition. Cytokine release syndrome. So in this patient, you have to monitor your triglyceride, especially if you're using parenteral nutrition. And as these patients are sedated, most probably prone, you should put in your mind that they are receiving a big amount or some amount of propofol that can be must be subtracted from the total triglyceride use for this patient. And the recommendations are avoid aerosolization as with indirect calorimeter. So you're not using your indirect calorimeter. Instead, you're using your weight-based energy estimation equation. Assess always for refeeding, and you start slow and increase your requirement within 5 to 7 days. Just giving your patient 25% of their caloric goal in the first few days and increase slowly and closely monitor. You should start enteral nutrition in COVID-19 patients within 24 to 36 hours or within 12 hours of intubation. When starting enteral nutrition, you should use a low dose, 10 to 20 ml per hour, using high protein formulas, 1.5 kilocal per ml, and advancing to the 80% of the goal by the end of the first week. Check for gastric residual volume in this patient to avoid transmission of infection. Deliver enteral nutrition continuously into the stomach. Switch to parenteral nutrition when enteral nutrition with gastric feeding is not an option. In patients with renal failure undergoing renal replacement therapy, providing proteins 2 to 2.5 grams per kg adjusted body weight and monitor micronutrient intake. Limit soybean, especially in the first week, and monitor for toning. Use enteral over parenteral is advisable. Attempt enteral nutrition via gastric feeding during an enteral and parenteral nutrition are contraindicated in hemodynamically unstable patients. There is no specific data with regard to fish oil, probiotics, vitamin, and mineral with respect to COVID-19 patients. This would bring us to the summary of what we already stated. Malnutrition does impact critically ill patients. We knew that nutrition support consists of assessment, the route, the timing, the type, the site, and monitoring. Enteral nutrition is recommended when possible over parenteral nutrition, of course, and there are specific considerations with respect to the current pandemic of COVID-19 in critically ill patients. And thank you.
Thank you, Dr. Noha. Really,
Professor.
You never failed really to attract our attention for this really nice review for the management of the critically ill patient in the setting of the critical care medicine, and as well as I enjoyed really your input about the changes and I mean the impact of the COVID in your daily practice with the nutrition, and that what actually takes us to another question here has been put there by one of our colleagues in COVID patients on the mechanical ventilation, which is the most preference. Let me say it, going to the enteral nutrition or the PBN or the parenteral nutrition.
The recommendation already stated in the last slides that it's advisable to go on to enteral nutrition in COVID-19 prone patient, unless the patient has a high risk of aspiration, malnourished, cannot achieve his total intake by during the proning, then you go for supplemental nutrition.
That's amazing. And another question, do you consider severe acute pancreatitis as a contraindication for a gastric feeding?
We already stated that if the patient is not tolerating enteral nutrition using the tube feeding even, then it's time to consider supplemental parenteral or total parenteral.
Okay, so it's been not tolerating. So
not tolerating vomiting. Yeah.
All right. So that's actually we'll answer the next question, which is when would you start the feeding in such cases? So probably, I mean, if it's not tolerating, definitely we should shift to the other formulas. Am I right?
Yes, of course.
Yep. Wonderful. And just very quick question: how far you recommend the BEG in LTC patient?
In what patient?
In LTC. This is as per the question. Maybe it's not very clear because it's been using the abbreviation. But I have a personal question here. Do we still consider the propofol is a lipid content as well in your TPN? It should be subtracted
definitely it's calories, and you want to prevent overfeeding in critically ill patients. So you start small and you go slow and you escalate and you avoid refeeding, especially in critically ill. Most probably they are malnourished. They have been for more than 3 days not eating well. So if you give them all their caloric requirements, probably they'd end in the refeeding. So you have to start using Simon, and you have to consider the calories 50% first, and then escalate to the 70, and then achieve your target goal by the end of the first week.
And really, you achieved your target really with giving us a very, very interesting lecture here, Dr. Noha. Thank you very much for your presentation.
You're most welcome. Thank you.
Dr. Hazem, LTC, long-term care, and this question is very important by Professor Sahar Marzouk, please.
So what would I consider in long-term care?
Can I talk to Noha, please? Yes, Noha.
Yes. How are you, Dr.
Amazing, amazing, outstanding lecture, really, as usual, Noha.
Thank you, my dear professor.
So I have two questions. If you can allow the organizer to tell her the question.
Yes.
Please do. Yeah, go ahead.
Yes, please. Noha, according to your practice, how far you recommend LTC? You recommend PEG for LTC patient, long-term care patients?
Okay. Well, long-term care patients are classified according to their disease. So, in patients with final state of Alzheimer,
yes,
you should respect the patient and family wishes. At these stages, enteral nutrition is considered to improve the quality of life. So if the patient and the family would be easier on them using the PEG and they accept it, it's okay, it's better. It decreases the risk of aspiration, it will be easy. But if they psychologically refuse it, or the patient had before stated that he'd never like things like this to be given, so respect his will and use the tube feeding. Just advise them to keep the patient semi-sitting in bed, use a small amount, monitor for the risk of aspiration. Okay. If the patient in long-term facility has a problem with swallowing and he required the PEG because he would never eat without aspiration, then of course it's considered. It's much more better even than the post-pyloric, definitely.
Okay, thank you now so much. Regarding parenteral nutrition, how long we can use it?
Parenteral nutrition, there is no time limit for using parenteral nutrition. So if you can start enteral as soon as possible, of course, and keep the parenteral to be supplemented and then start on weaning. If you cannot start enteral, there is no time limit for using parenteral nutrition.
Okay, thank you so much.
You're most welcome.
You're welcome. You're most welcome. I think that's all for this session.
I think there is another question for Dr. Ala Salama. He's our friend from Switzerland.
Okay.
I'm sorry. Thanks for the wonderful presentation. I would like to know your take on intermittent or versus continuous gastric feeding.
Okay, intermittent versus continuous. Intermittent is much more physiologic. It's however, the volume used would be higher than continuous. Some facilities use this and the other use continuous. Continuous form, the problem with it are because they are expensive, they use specific sets, and you must have your pump, your infusion pump, and you use it. Of course, the studies and literature do recommend the continuous form, though it's not physiological. But it's just present in some centers in Egypt. Unfortunately, in Egypt, most of the hospital use intermittent because of the problem with the expenses.
Thank you.
You're most welcome.
Well, I think that's all for the questions. So thank you, Dr. Noha, for your amazing presentation that actually raised a lot of questions, a lot of queries from all the corners of the world. And this actually is all of us, I think, enjoyed really this nice presentation.